Okay, hello everybody. I'm Brian, and this is Amy News and Conversation. I'm here today with Britt Barrett, a very special guest who is part of our standards development world. But I'm going to let Britt introduce himself, tell us a little bit about what he does before we dive into today's topic. So, Britt, who are you?
Sure. Thanks, Brian. Britt Barrick. I'm with JLL Healthcare currently. And what I do is program development and implementation for JLL in the healthcare space. And that is programs essentially for operations and compliance. And that's some of my background. So I've been in healthcare my whole career. And starting off back in the late 70s, while I was in school, I was a biomed tech part-time. And when I got out, started to work for a community hospital, 450 beds, and worked there for 10, 12 years, doing department operations. So I worked, and I'm going to call it mostly in the analog era when everything was more transistor based. The first hospital I started with, their patient monitors had vacuum tubes. So been through a whole shift in the industry from the analog era all the way to microprocessors and beyond. So during that time, I've been involved in committees and standards, again, the whole career. So after the hospital, I started work with the American Hospital Association, AHA, and in their ASHE and Health Technology Management groups. And in that role, did a couple of projects. One of them was to help them redo a standard called maintenance management for medical equipment, which was basically, I'm going to call it much like a cookbook of maintenance procedures and the time it takes to do PMs for medical equipment. So I got together some experts and we did this documentation. And we put in how what the frequencies of PMs were supposed to be and et cetera. So it was very, again, like a cookbook.
Yeah, and this was the early days of our equipment management committee, as far as I know, right?
Absolutely, yeah. And I got involved while I was with the AHA with this project, and also that's when I first went on the equipment management committee, and I was worked on the EQ 56 standard when it was first being developed. So Ethan Hertz was a chair with Duke University, and I was with the AHA, and there was a number of other people on the committee, of course. And given my background and the role at AHA, I'm trying to represent the common man. So this standard was developed to provide guidance on how to manage a biomed department, and it was a recommended practice. So it had a lot of guidance material in it, and it gave you how to do PMs, how to budget for equipment acquisitions, how to staff a department, how to do inventories, those kind of things. So I was on the committee for several years doing that, and I worked through the first edition of EQ 56, which came out in 1999.
Okay, and for a lot of the folks who might be watching this video, Britt is probably a familiar face. He's been involved with Amy's standards, particularly the EQ committee, the equipment management committee for our HTM world for over 3 decades. So Britt has a lot of industry experience and a lot of know-how. And today we wanted to talk about a new standard that is officially becoming a full standard. That's EQ 56. So you folks will probably be seeing that in the news. But almost what I want to touch on more is everything that led up to that, the change in the industry and why we need this kind of work. So, Britt, why don't you tell me a little bit about those early days? You had mentioned you were working with AHA, is that right?
Yeah, that's correct, Brian. So, in that role, I was involved in a couple projects. One was the maintenance management for medical equipment, which was a very prescriptive for analog equipment. It was an appropriate guidance, and it gave how to PM suggestions on how to PM equipment, when it should be PM, and etc. At the same time, Ethan Hertz was the chairman of the committee that founded EQ 56, and he was developing a standard for department management. and I got involved in that and with the AHA, and was on
Just to
that committee for a
hold
number
you
of
on there
years.
right there, when you say department management, are we talking about the management of the staff or the management of say work orders, things like that?
Yeah, the whole all aspects of the department.
Oh wow. Yeah.
So everything from how to do the inventories, how to hire, training requirements, even down to how many square feet a technician should have. So again, it was helpful guidance because there was none. And some people thought it might be a little too prescriptive. You know, management is not a prescriptive type. It's not a cookbook like the maintenance management document
That's fair.
was.
You need a little bit of flexibility.
That's exactly right. So after the AHA, I moved on to the Joint Commission, and the problem there was that again, with the analog equipment, to have a prescriptive time frame for doing maintenance, semi-annual if it was high risk, annual if it was low risk, and that's how they surveyed you. But with the evolution of microprocessor and digital equipment didn't fail like that. Some equipment did, but a lot of it was not. And there was other leaders in the industry, Dr. Vincent Wang, for instance, who used to give me a lot of advice while I was at the Joint Commission about how we need to change things. So we actually changed the standards to say, when it came to equipment maintenance, that you just develop a maintenance strategy, and then we would score you against your strategies. So we thought that was helpful to get people out of just the rote cookbook kind of thing.
Introduce that flexibility you're talking about.
Right.
I find it interesting too that you're talking about these, these analog devices. And I'm assuming this is in a time where we're also seeing, for the first time, maybe health IT departments start making their way into hospitals, things like that.
Absolutely.
And these days, it's common. People talk about the gray area between HTM and health IT, but it doesn't sound like it was the case back then.
Well, back in the day, we since we knew more about electronics, we were setting up networks and setting up their servers and maintaining their equipment. In addition to the medical equipment, anything that was associated with scheduling in the OR to the lab equipment and everything, we were involved in that as well. So we've always been intertwined. And then slowly, as I was leaving in the late 90s, the IT departments were becoming more prevalent. So they definitely.
So a lot to think about in terms of, say, program management and your equipment management. Yeah, no, that's very fascinating. I know we've also talked about, when you were on our alternative equipment management group as well. There's a new standard coming out from that. We'll put the link in the description for people who want to know more. But a whole nother standard that was being developed at the same time or a little bit later. Again, why is that important? We're talking about flexibility here, so I was curious.
Yeah, that was and these things are all related. Again, as equipment developed and became more reliable, we started moving in that direction, and then the brakes were put on a little bit by CMS, and they put out a couple of what they call S&C letters, standards and compliance letters, that directed people to use the OEM manufacturer for their equipment maintenance. And so there was pushback on that. So it seemed to, limit some of that flexibility. So there were a couple documents in the interim that came up just preceding this time. I was working with on the equipment management committee on a document called EQ89, which is a guideline for the use. Whoa.
I love that you have it right there. Yeah.
Yeah. Well,
this man's developing standards every day.
Yeah. So this was for guidelines for developing maintenance strategies. So we were thinking, well, this is great, and we wove in a lot of reliability type of language about how to detect. I mean, what kind of failures are important? Hidden failures are more important to diagnose and correct than latent failures, ones that the operator can notice, stuff like that. And we try to, and this is all based on a lot of the reliability engineering work that had been going on in the aircraft industry and automotive industry, petroleum. A lot of industries had adopted this. years ago, the military, NASA, things like RCM, which people have heard about. So reliability engineering, we're trying to get that into the standard. And then suddenly CMS came along and kind of put the brakes on that. So we did respond to they did revise their S&C letter a little bit, enough to allow us to do what they would call, you can do an alternative equipment maintenance program. And so that was the genesis of developing the AEM standards. Maggie Berkeley and Colleen were the chairs of that committee, and they really did a great job with that document. But once again, we're trying not to be, we're moving away from prescriptive type approaches. A lot of people have said, well, we have a system that works. Why don't you make that the standard? And say, no, well, let's back up. And what are the attributes of your system that make it so good? We'll put that into the standard. And, people can do it a different way if they want to. One thing would be,
not all hospitals are created equal, right?
No, that's absolutely correct. You've seen one. We just wanted to put the guardrails on it. And I think some of what we read from CMS was, well, that's fine if you alter a procedure or a frequency or whatever, that you need to monitor to make sure that change that you made is still does not decrease the level of safety in the device. So there's an obligation, if you want to change things, that you monitor the results and make sure that you're still delivering good, safe patient care to the patients.
I love the idea here that there's this narrative going on between the Joint Commission, CMS, and the other standards developing folks in the room. Who was in the room? Like, who is normally working with you and Colleen and those other folks you mentioned, Maggie, as well?
There's a long list, and I could read off names, but let me put it this way: they're coming from a lot of different backgrounds.
There you go. Yeah.
Co-chair was Steris, who's an equipment manufacturer. There are people, Maggie is coming from a healthcare setting, Colleen from a contract providing service. I'm contract management, so I'm in a lot of hospitals all the time, and I see just the wide gamut of operations. So I think those kind of discussions are very helpful in the standards development process, and not only with the AEM standard, but also with the EQ 56, which went from more of I'm going to say from the early genesis was more prescriptive in the minds of many. And we really tried to distill out the guidance part and convert it to a standard, which just, again, describe attributes of your management process. I know that Dennis had described some of the new chapters, quality management chapters, continuity care of services. Those chapters were new, and they were all based on, a broader spectrum of management techniques that should be, baked into your programs. So.
Something I had heard from a lot of folks when they were excitedly talking about EQ 56, which will be coming out soon, is that, the fact that it's being converted into a national standard is a big deal, because it initially, for a long time, has been essentially recommendations. What's the difference now that it's a standard?
Yeah, recommended practice is, well, number one, it's easier to write recommended practice, and because you can just go on and on. And one of the problems, we had a long document which had explanatory notes, and they would talk about here's how you could do an inventory, and here's how to buy equipment. We said, okay, what's the essential pieces of this long recommended action? What do you absolutely need to do, and really to word it? And sometimes knocking 3 or 4 paragraphs down to 3 or 4 words. Some of that is easy, but the last 3 or 4 words are pretty tough to get down and get exactly what the meaning you want, that distill out the essential parts of the piece. So it was and I'm going to say that we did a lot of work on it. There was a lot of Fridays, when we get stuck or hung up, we would create a subgroup of, okay, who are the people that have the, the most to say about this issue, and let's put them off. They went on a little bit of a sidebar, came back to discussed it, and then came back to the committee and then presented it to the group. So that was helpful. I think people benefited a lot from being on the committee. Again, everybody's coming from different backgrounds, and they know their world, and they hear about other things that are going on. I believe I learned a lot each and every call, and I feel that the people on the meetings and the committee meetings were learning a lot too. And we try to have some fun with it as well, because there was personalities, and we knew who everybody was and how they would react. And so I thought it was a good process.
I do love when I hear about certain standards groups, they say, oh yeah, we have fun. But at the same time, it's competing companies in the same room. It's consultants versus regulators, things like that. And yet they all get together, and you have to come to an agreement. There has to be some kind of consensus, or that document's never going to get out the door.
Right. Yeah, it is. I think a lot of people just leave the shingle at the door, and they when they join a meeting, they get it. It's great. You never know when you might be on the other side of that fence, right? So, I mean, I was with AHA. It was kind of like the guardian of the flock, and then the Joint Commission is seen as the the protagonist. So they're one side and the other side of the fence. So you never know if you're going to be the hunted or the hunter, I guess.
Oh, that's very fair. No, that's great. And that's the kind of valuable, I guess, perspectives that these groups need. People maybe who's worn multiple hats, or at least will have somebody wearing each hat. So I wanted to finally, we'll close off here by talking about the evolution of the EQ committee. And we talked a lot about then versus now, but I wanted to say, what do you think about the future, right? Are there any standards or next steps that you're kind of looking forward to for the committee as a whole, or even just the EQ 56 group?
Well, yeah, I think the Medical Equipment Management Committee, when I started, there were two documents in the hopper, and before long, we had 1, 2, 3, 4, 5, 6, 7 projects that the board sent to us. And some of them we had to put on the side. I mean, 56 was a big effort. It was way behind schedule, and COVID was interrupted the middle of it. So we really had to reboot the whole thing and start over. So they do.
I'm sure technology changed by the time you had to reboot, right?
Well, it's a management standard, so yes, it did change. And a lot of things. You mentioned IT earlier, and there's standards for medical devices, or standards for IT service, and people, they approach service differently. And since we have to work with IT, I mean, it's the technologies are hand in glove. We have to know when they use certain language, we have to know what they're talking about. That as I'm speaking as a biomed, and vice versa. We're trying to get some of that common ground laid out, and some people might have had a reluctance at first, but I think they all got it. That we know, we might be trying to do the same thing. They call it this, and we call it that because of a tradition, but business continuity, if you want to call it that, or emergency management, if you're a healthcare person, it's all the same. The goal is the same. So trying to get some common ground in that. So I think some of the new chapters were pretty interesting. And I think people will hopefully they'll embrace them.
Right. So. Yeah. So what comes next?
There's like I said, there's a number of projects we have to put on the back burner. So a couple of them we were working on an acquisition guidance. So buying new equipment. Sometimes you don't get purchasing does it, right? And then we pay for it. They save $1 and then it costs us a fortune. So to get them to standardize, to get them to do the evaluations, those things, I think that was a very that was a worthwhile task. There's one on education. So this is the curriculum for education programs. So standardizing that. And EQ 89, the maintenance strategy, that one's going to come around for reassessment. So I hope there's an opportunity to put more reliability concepts into that document, because I think that there's a lot of value into that. And again, it's mostly the language is different. Sometimes it's because it comes from some other industries. They use words like run to fail. People, like on the committee, they suggested, well, that's not real palatable in healthcare. Mom is on the other side of that ID, but they'll run to repair or replace. So, okay, that sounds a little bit better. So we're going to run until we have to fix it, or we can decide to replace it with something, another one. If it's not, it's repaired. So, well, I think the semantics really get in the way of a lot of the understanding sometimes.
I guess that's what standards is all about, right? We got to standardize the semantics, and then we can take the next steps, all for patient safety. Yeah. Well, Britt, I appreciate you kind of giving me almost like a primer on what the EQ committee has been all about these last 30 years. And as you said, all these new standards are just beginning to ramp up or are just coming out for the HTM community. I love to see it because HTM has been a bit behind the other industries in terms of standards. So it's good to see it coming to fruition. Anything else you want to add before we close off?
No, I think that was a good way to sum up, Brian. It was you did it better than I could. So we'll get you on the committee.
Oh no, you're gonna give me more work. All right, it was great meeting you.
Mm-hmm. All right, thanks, Brian.